My name's Hugh Kearney. I'm a neurology consultant in St. James's Hospital, and I'm going to talk this evening about being newly diagnosed with MS. So this is kind of an overview about what I'm going to talk about. An awful lot you could say, but I'm just going to try and touch on each of these topics, even briefly. And then if there's any particular questions, I'm very happy at the end to go into anything in more detail if there's something you feel that wasn't covered. So what I'm going to talk about first is what is MS? So MS is a disease. It's where the immune system attacks the coating of the nerves in the brain and the spinal cord. And then if you think about it, the symptoms you experience are as a result of that. So all the symptoms come from what's called the central nervous system, and that's the brain and the spinal cord. Once the nerves leave the spinal cord, that becomes the peripheral nervous system. There are other diseases that can affect there, but the central nerves mainly show up as symptoms when it's something that can't be replaced by another part of the nervous system. So for example, if you think about the nerves that come back from your eyes, they're called the optic nerves. If they're affected, there really isn't another one to take its place. So that's why the symptoms come out quite quickly. Or if there's a problem in the spinal cord, there's only one spinal cord. So things like numbness in legs or stiffness in legs or trouble with bladder, those type of things, they're usually kind of come out as symptoms quite quickly. And this is as a result of the distribution of where is affected in MS. So it's a disease that affects 2.8 million people worldwide. There's about 9,000 people in Ireland with MS. And 3/4 of the people with MS are women, but it does, of course, affect men too. It usually begins between age 20 to 40, as a lot of immune diseases do, and this is a disease of the immune system. So next, touching on what are the symptoms. So there are kind of common symptoms of MS, and I suppose one of the things that we're aware of is they differ a lot from person to person. And also how each person experiences and responds to the different symptoms can differ greatly as well. Some things can come and go. They can vary in terms of one person could be severely affected by one thing and not so much by another. And someone else might have a different experience. And that's why it's very personal. And the other thing is that for somebody who doesn't know that you have MS, the problems might be invisible because they're within the nervous system. Unless it's something that the person is, dealing with you in a particular circumstance, they mightn't have any awareness. So the common things that people with MS would describe, fatigue is a big part of it. It's, as some of you will be aware, it's beyond what people would describe as sort of usual tiredness or feeling a bit run down. It can be what many people with MS would describe as the worst symptom or the symptom that bothers them most. There are many other things, but this cartoon sort of highlights some of the more common ones. So vertigo, which is a sense of imbalance. People can get visual problems, sexual dysfunction, bladder or bowel symptoms, cramps or spasms in muscles, or kind of a slowing of thinking or slowing of thought process, as well as mood problems such as depression or anxiety. One of the things that we do know about in terms of the brain and how it works is this concept of neuroplasticity. And this is that our brains have the ability to regenerate and reorganize themselves. So if the brain is injured in some way, shape, or form, by using it and continuing to use it, you have the chance of repair happening. And that's why it's so important to work with physio and occupational therapy, because it actually changes how your brain works. So when the physiotherapist gives you balance exercises, for example, by doing that, you're retraining a different network, if you like, and a different pathway, which reorganizes how the whole thing works. And that gives the possibility for improvement. Next, moving on to how is MS diagnosed? So usually most people start by presenting to their GP or maybe to another hospital doctor. And from that point, a GP or another hospital doctor might pick up that there's something here that sounds like it's coming from the nervous system. And usually the pathway would be to be referred to a neurologist. And the way it would work for a neurologist is first thing they want to know is the story. what happened to you, what part of your body was affected, when did it come on, how did it come on, were you well, was there anything else? These kind of questions. And they might ask you other questions about your past history and so on and so forth. Then usually a neurologist would do an examination and check things like your balance, your strength, your coordination, and your reflexes and those type of things. And that kind of helps to put the whole thing in context. Once you kind of have the context, there are some tests that are usually done. So there are blood tests that are done routinely. And the reason blood tests are done is to rule out things that look like MS. So as it stands, there's no blood test to tell you a person does have MS, but there are many things that can look like it. And I suppose you just have to make sure that they're not present. The next test would often be a scan. And this is just a picture of an MRI scanner. So usually the scan is of the brain, and sometimes it's of a bit of the spinal cord or maybe all of the spinal cord, depending. And what you look for then are kind of bright dots in a particular, that have a particular shape and a particular pattern. And there are rules that are then applied to say, do these dots match up with what we know MS looks like? And then the last test is this, what this cartoon shows here, which is a lumbar puncture. And the purpose of this is to take a sample of spinal fluid. And what we look for in the lab is to see if there's signs of inflammation in the spinal fluid. We then take a blood test immediately afterwards or maybe before, and we look for inflammation in the blood. And what you would see in MS is that there's inflammation in the spinal fluid that's not in the blood. And that's very characteristic of MS. And the particular thing we're looking for are called oligoclonal bands. And about 90 to 95% of people with MS would have them. So when you have been diagnosed, it's natural to wonder how MS would change your life, your relationships, and it's natural to have a lot of questions. So the kind of advice usually would be to educate yourself about MS, to choose your support team, to kind of be in tune with yourself, to strengthen any existing relationships, and as much as possible to take control of the situation, but also to plan for unexpected happenings. A question then that often arises, what are the types of MS? So there are three types. Firstly, relapsing remitting, and that's here at the top. And this is where people get attacks, where the immune system attacks their nerves. There's usually a first one, which is what brings it all to attention, or maybe on a second or a third one, depending. And there's usually a degree of recovery in between. It's not always 100%, and most people would say they have some residual symptoms after an attack. And those residual symptoms might come out if their body is heated up, or if they're under a lot of stress, or if they have an illness of some other kind. Some people with relapsing remitting MS develop what's called secondary progressive MS. And this doesn't happen to everybody, but this is where walking distance primarily is affected, and it becomes increasingly difficult to walk. In the past, before drugs were available to treat MS, this used to happen a little bit earlier. But now with drugs that treat the disease itself, we're seeing that this happens much later and to a much lesser degree. So what we're seeing overall is that the natural history of MS is being changed by the drugs we're using. The last type of MS is primary progressive MS, and this is the least common. It accounts for about 15% of all MS, and it tends to happen in men a little bit more than women. And usually later in life as well. And it presents usually with walking difficulties from the beginning, but there can be different presentations depending. So a question that we're always asked, and everybody, well, most people would have this at the forefront of their mind, is why do people get MS? So there are different sort of risk factors, if you like. So genetics does play a role. There isn't an MS gene per se, but there are certain genetic makeups that design your immune system that can kind of prime your immune system to turn on itself. So having somebody in the family who has MS, it slightly increases the risk, but not to the extent of a disease, for example, like cystic fibrosis, where there's a gene passed down through the family. The next thing that's important is where you're born in the world. So if you're born on the equator, basically nobody gets MS. And as you move further north and further south away from the equator, more and more people do. And even within Ireland, there's more MS in Donegal than there is in Wexford. So there's this sort of gradient. And the thing that we think is a factor here is vitamin D, because the sun shines the most on the equator. As you move further north or south, there's less sun, and so there's less vitamin D. And vitamin D seems to play a role in how your immune system works. And then the thing that's very topical at the moment, and it's really come to the fore in a study from Harvard in the last couple of months, is this virus called Epstein-Barr virus. I won't talk about it too much because there's an awful lot of other things to get through, but I was aware there was a recent webinar on Epstein-Barr virus dedicated wholly to this. But it's just to say that for many years, for probably about 20 years, it's been debated back and forth whether Epstein-Barr virus plays a role. And now the evidence would seem to suggest that it does. What we think happens is that Epstein-Barr virus primes your immune system. And what it does is inside of Epstein-Barr virus, there's a protein called EBNA1, and EBNA1 seems to look very like the coating of your nerves. So your immune system, while trying to go after the virus to kill it, actually gets tricked and goes after the coating of your nerves. And this concept is called molecular mimicry. So that's what we think is going on with Epstein-Barr virus, and it opens a lot of questions, and it's probably very early days, but it does give, again, cause for hope, because potentially new treatments might come out that target this, or even in the future, again, there are vaccines that are being developed that we hope might reduce Epstein-Barr virus and then reduce people's chances of getting MS. But we're a bit of a way off that, but these are all sort of things for the future. The other things that are important are smoking. If you smoke, it does increase your risk of MS, and it does increase your risk of other immune diseases. Having low vitamin D levels can be important, and that ties into where you're born. And then obesity in adolescence is also an important risk factor. The reason this is the case is that fat tissue releases what are called inflammatory cytokines, so it kind of revs up your immune system a bit more. And that's why we think obesity plays a role. The next question that we're often asked and people want to know when they've been newly diagnosed is, what is a relapse? So there's this long definition, and this is kind of the internationally recognized definition of a relapse. But essentially, it's new symptoms that you haven't had before. So if you had a first attack of MS, you'd kind of know yourself, I have had this problem and it might come and go if things are bad. But if you have something that's brand new and you've never had it before, and you feel overall very fatigued, really tired, and that symptom lasts for more than a day, and you don't have an infection and you're otherwise well, then it's probably a relapse. And that's kind of, I suppose, in essence, what it is. It can present in any way. So any of the symptoms that MS causes could be part of a relapse. So for example, you could get new trouble with your eyes, you could get new trouble with balance, new numbness in your legs, weakness in an arm or a leg, or maybe a change in your thinking where you feel like your thinking has slowed down, but you were feeling good up to that point there. So it could be anything along those lines. And again, it's individual, and it very much depends where the MS is targeted in the nervous system. So this is kind of to highlight. So it's the same cartoon that I showed at the start, showing common symptoms of MS. So for example, things that people might experience would be vertigo, where, a sense that the room is spinning and they're going to fall down. But they might experience that in a very bad way during a relapse. Or you might find that muscle cramps or spasms really ramp up. And whichever symptoms sort of come out during the attack or the relapse, fatigue is a big part of it, and sort of beyond background level fatigue. So that's kind of sometimes a telltale sign that this is a relapse rather than something old. There is always a bit of confusion whether, is this my old symptom or is this new? And I suppose this is something I mentioned already. If the body is under stress, old MS relapses, they can seem like they're new again, but there are lots of things that can do it. So for example, an infection like a urinary tract infection, raised body temperature, stress, just general stress of life, fatigue from other causes, or hormonal changes during menstruation or menopause can make an old relapse seem very new and very real again. And then the question is, do I need steroids or do I need to change medicines? And it's a case of teasing out. So probably talking with your neurologist or your MS nurse as to what's old and what's new. And then maybe a common thing that we'd often ask would be for people to get a urine dipstick, just to make sure that there isn't an infection there and to check their temperature with a thermometer. So I'm going to move on to sort of treatments for MS, and this is a big thing, and it's, as I mentioned already, it's changed so much in the past 20 years, and it continues to evolve very rapidly. One of the things that's unique about MS is that we have medicines that change the course of the disease, and it's the only neurological disease that I know of that's the case. There are very many neurological disorders, and all of them are treated, but in all the other diseases, it's the symptoms that are treated. Whereas in MS, it's the disease itself that's treated with the medicines. And that's what's different about MS. So we kind of break up the treatment into two bits: how we modify the disease, and that's sort of, it's a big thing, and rightly people want a lot of information about this. And the other side of it is treating the symptoms. So we kind of, in our minds, we break it up into these two parts. So if we talk about disease modification first, the first port of call is the MS nurse. And for those of you who've been diagnosed with MS, you'll kind of quickly get, hopefully, to meet your MS nurse. And you realize as time goes by how invaluable the nurse is just for every single part of your journey with MS. When you're diagnosed with MS initially, usually there'll be a discussion about what medicine might be appropriate. And there's a long list. So, at the moment, there are over 15 drugs approved, and there are more coming on stream. So we would anticipate in the next few years, there'll probably be close to 20-something medicines approved, which is really quite remarkable given where we came from, where there was a single drug called interferon, and now you can see the list below. So in terms of then meeting with your nurse will give you some education as to the pros and cons of each medicine. No medicine is perfect, but any medicine is better than none. So any medicine that we have, we've evidence that it does have an impact on the number of relapses. Some of them seem to impact a little bit more on the progression of MS. And what I've done is kind of broken them up into sort of different categories, if you like, here. So on the left, we have tablet forms, and I've just given the names. I haven't gone into great detail on each of these, but if there are specific questions, I can answer them later. Then there are some medicines you inject yourselves, and the newest one here is Kesimpta. There are other ones, Copaxone and Rebif, and there are other forms of interferon, of course. Then there are infusions, which are kind of like a drip, and usually the way we kind of break this up is that the tablets you take yourself at home, the injections you'd usually do yourself at home. You'd have a nurse guide you with the first few, and then after that you'd do your own injections. But the infusions would always be done in the hospital, and they'd be with a nurse, maybe your own MS nurse or maybe a nurse in the infusion unit, depending on the hospital and the setting and so on. But I suppose the point is there's plenty of choice for medicine, and we kind of think about the medicines in terms of tiers. So we'd sort of think of them as first line, second line, third line, and so on. And broadly, what they do is they're kind of two strategies. They act on what are called B cells and T cells, and these are the main cells of the immune system. And what these medicines do is they can either break these cells up, so they can break up the B cells, break up the T cells, or else stop them from replicating. And the idea here is that if you sort of dial down the immune system, it gives your nervous system a chance to recover from the attacks of MS. And the other way is to block cells. So you can do that in kind of two ways. You can hold the cells into the lymph nodes, like keep them in jail kind of idea, or you can block them from going across what's called the blood-brain barrier. So there's a series of blood vessels that protects our brain. And in MS, the immune cells get through and attack. But if you can block them off, hold them off at the pass, then that has a good effect. So they're the kind of different ways you can either block or break up the cells. Then in terms of treating the symptoms, again, the person who's sort of at the heart of it all is the MS nurse. So if there is a symptom, usually people would discuss it at their appointment with their neurologist. But in between times, things might crop up that weren't so bad or maybe weren't apparent at the time of the appointment. And then what most people would do would be to contact their MS nurse. So there are kind of different ways symptoms can be treated. It can be with tablets, if it's pain or discomfort or maybe stiffness in muscles. It can be with occupational therapy. It can be with counseling or psychologist if there's a mental health component, or it can be with physiotherapy, depending on the nature of the symptom. So again, it's very personalized, and it very much depends on the person, what symptom is the biggest problem and what can be done to help. Overall, there are what are known as brain health strategies, and this applies beyond MS. So this could be for anybody in any walk of life. But I suppose, given that MS is a disease that does impact on the brain, sort of have to have a particular awareness that you want to keep your brain healthy and well as best as you can. So it's just kind of things that we know from evidence-based studies does help to keep your brain healthy and well. So the first thing is, well, there are lots of do's here and not many don'ts. That's the good news. So we do recommend that people stay physically active. It doesn't mean you have to do anything heroic. So even going for a walk 2 or 3 nights a week would make a big difference. The reason that's the case, well, there are a few reasons. The first is that when you move your body, your muscles release a hormone, and that hormone is called brain-derived neurotrophic factor. But in plain English, what that means is that your muscles release a hormone that helps your brain to grow bigger. So it actually makes your brain healthier to move, and the more you move, the better. It can be swimming, it can be Pilates, it can be yoga, whatever you feel you're up to at that point in time. The other advantage of staying physically active is that it keeps your heart and lungs healthy. And we know that as time goes by, MS lesions in the brain, they tend to form around the blood vessels. So if you can keep healthy, it keeps your blood pressure low. It tends to keep you overall, your circulation in better shape. And then that has a very positive effect as time goes by. The next big thing is to kind of find who's going to support you. And it depends. It can be friends, it can be family, it can be work colleagues, it can be community workers. It's very personal. And it's a case of just sort of working out for yourself who would be sort of in your own personal support team. A bit like then keeping your body active, it's important to keep your mind active. And again, there's no right way of doing this, and there are many, many options. So it doesn't have to be anything formalized, like a course or anything like that, but reading the newspaper, reading a book, listening to the radio, listening to music, doing puzzles, engaging in things, discussions, whatever the case may be. Anything that engages your mind is really healthy and very helpful. And then kind of tying in with the physically active part is keeping your body weight under control. Because we know that being overweight in adolescence increases your risk of MS, then if people do have MS and also have an increase in their body weight, it does seem to have a negative impact. So it's just sort of watching your diet. There's one don't, and that's don't smoke. And this would be the only thing we ever say, or I would ever say in clinic, to not do. The reason we say don't smoke is it accelerates MS. It accelerates the disease. It's kind of like if you're in a car, it's like putting your foot on the accelerator if you smoke. It really drives the disease really fast, really hard. It makes the whole thing so much worse, so much quicker. And if you smoke a lot, unfortunately, it kind of limits how well the medicines will work. So really, that's the only thing we would ever say to not do at all. Drink is no problem, but I suppose like everyone, it's just kind of in moderation. We sort of would suggest to try and avoid stress. That's easy to say, but in real life, it's a case of managing stress rather than avoiding it, and having coping strategies. So it goes back to sort of who's in your network, who supports you. So if you're having a difficulty in work, can you talk to your partner, your husband, your wife, your friend, your colleague, whoever it is, so that if there's stress, you have ways and outlets to de-stress. So by doing things like Pilates or going for a walk or meeting your friend for a coffee or whatever it is, that you've something that you can do that can let stress off. And then many people with MS also have other medical conditions. So for example, some people have diabetes, or they might have asthma, or they might have, there's a long list of things, or low thyroid, or whatever the case may be. But it's important to also look after these other things, whatever the other disease might be. And the reason is that if people with MS have another disease, if the other disease isn't held in check, it can have a negative impact on the MS. So it's just to kind of, even though MS can sort of seem to take over everything, just not to forget about other things that are maybe less to the forefront. So to check in with your GP if you do have asthma, or if you do have low thyroid, just even once or twice a year, that things are all okay from that point of view. So we're just coming to the end now. I'm just going to wrap up with a few final points. So firstly, just to emphasize again that the medicines we have now have definitely changed the natural history of MS. So any drug, any disease-modifying drug has changed what MS does and how the outcome is. There are a number of new treatments that are going to emerge probably in the next 5 years, and that would be on top of the existing 15 medicines we have available. And lastly, there's ongoing scientific research, and I think that this will further advance our understanding of MS. And then the hope would be that this would lead to even more precise treatments and even better treatments, so that the outcomes will be better again, and MS would have a much lesser impact on people's lives. So that's it from me. Thank you all very much for your attention, and I'll just stop sharing my screen and then be able to take any questions that people have. Yeah, that's a really important question. So when there's a lesion acutely, it tends to be very swollen and it looks very big on a scan. As time goes by, it usually tends to shrink down, but it doesn't go away 100%. And the reason we think is that there's a lack of repair and sometimes a bit of scarring that forms, and it depends. There are different types of lesions. But ultimately, what we would like is to have a treatment available that would remyelinate the nerve, so to put the coating back on it. And there's a huge amount of research going into that. There's a group in Edinburgh who've been working on it for many years, and there's an Irish scientist called Denise Fitzgerald in Belfast, whose whole research is centered on that question of remyelination. So there have been various medicines that have kind of gone into trials to see if they can take effect. The latest thing that's come out is an antihistamine called clemastine. Now, it hasn't got to the point that we could necessarily recommend it or prescribe it, but the early kind of hints are that it's showing some signs that it might have a role in that effect. But there are going to be more advanced medicines that I think will probably come out in the passage of time to remyelinate the nerves. And that ultimately we would hope would sort of give back, as you say yourself, the lesion. Yeah, so I suppose with a lot of vitamins and supplements, different people would kind of as I was kind of trying to get out in the talk, it's very personal. And some people might find a benefit from something like B1, or some people with B12, or some people with different vitamins and supplements. At the moment, we don't really have a scientific evidence base to suggest that one vitamin would be worth taking. So if it's something you want to take yourself and it's not doing any harm, you know, nobody would say not to, but we wouldn't necessarily in the clinic say to everybody as a whole, you should be taking this or that. I think the exception to that is vitamin D. And the reason is that for sort of overall general health, we would usually check people's vitamin D level in the clinic, because it has an important role for the immune system and for bone health. And particularly in MS, where people might be given steroids if they have an attack or relapse, that can have a thinning effect on the bones. So we're very aware that we want to keep people's bones healthy for the long term. And I suppose living in Ireland too, you know, we don't get that much sunshine, even though my picture behind me might suggest otherwise. For the most part, we don't see that much sun. And the main source of vitamin D is the sun. So if you can get half an hour of sunshine, that gives you all the vitamin D for the day that you would need in terms of meeting your daily requirement. But for most of us, that's not realistic, and particularly in the winter months. So vitamin D, if we do find a deficiency in it, or if it's a low level of vitamin D, we would definitely, we'd usually prescribe a vitamin D replacement. So I suppose the short answer is lesions don't tell the whole story. What lesions on a scan are markers of, it's a marker of inflammation. And there are kind of two sides to MS, if you like. And one is the inflammatory side, which is kind of like the fire from the immune system that's damaging the nerves. But the second side are the nerves themselves, and they can break down, you know, to differing degrees from person to person. When there's kind of breakdown of the nerves, you get loss of the brain tissue, and you tend not to see that on a scan so well. And the reason is that the scan gives you a picture that the radiologist can say, look, there's lesions here, there's lesions there, but it doesn't measure the volume of the brain. And so in a research setting, when you measure the volume of the brain, you can see that the volume changes over time. And there are certain structures in the brain where the volume changes with a reduction in volume, that seems to tie in much stronger, much more with the progression that you're talking about rather than the lesions. So when you're told in clinic, oh, your scan is stable, in one sense, it's good news, but it doesn't answer everything. And I suppose it's a bit like the initial question about can we repair or can we get rid of the lesions? And this is another really important side of MS research. It's what's called neuroprotection. So what we're looking for are medicines that can protect the nerves from damage. So there's been a big study in the UK called the MS STAT trial. And this was run by an investigator called Jeremy Chataway. And what he did was he looked at people with what's called secondary progressive MS, and he gave them a drug called simvastatin, which is a commonly used anti-cholesterol drug. And over the course of a couple of years, he looked what effect does that have on brain volume. And what it did was it slowed it down. It slowed down the loss of brain volume. And that was really exciting because for the first time ever, it's a very simple, very cheap medicine. It only costs a couple of cents per tablet. And it meant that this was the first glimpse of a medicine that could actually protect the nerves. So now what's happened is that this trial that was called MS STAT has gone into a bigger trial called MS STAT 2, which is a phase 3 trial. And sorry for all the technical stuff, but it's just what phase 3 means is if that's positive, that medicine can get regulatory approval for that purpose. And you probably would have heard a lot of that kind of talk with vaccines for COVID and that type of thing, phase 2, phase 3, blah, blah, blah. But in essence, phase 3 means that you're on the cusp of getting approval from the regulators. And if something is approved by a regulator, it means your doctor can prescribe it for that purpose. So as it stands, what we tend to do in clinic is we check people's cholesterol. If it's raised at all, even a touch, we'll give them this medicine. But we can't sort of prescribe it straight off the bat. And this trial, if it's positive, would allow us to do that. And because we know it's a medicine that's generally free of side effects, is safe, and we know that many millions of people are taking it for high cholesterol. So it's not something that's not been tried or tested. And there are millions of years of patient history in terms of people taking it. So that's one example, but there are many others. And there's a large trial about to start in the UK, again, called the Octopus trial. And the Octopus trial is, they came up with that name because it's a multi-arm, multi-stage trial. So what they're going to do is get a very large group of people with progressive MS and break it up into lots of different arms and give people different medicines that the investigators think will protect the brain. And if one medicine is working, the people will continue on that. And if it's not working, then those people will be switched to a different arm of the trial. And they'll kind of keep going along like that till there's one horse that wins at the end of the race. And that medicine, we would hope, could then be offered to people across the board in any center or at any setting. So I suppose the point is really there's a huge amount of work being done on this. It is a bit slower than the other disease modifying drugs because it takes time. These drugs are being repurposed. They're older drugs. So the trials are being run by academics or researchers rather than pharmaceutically led trials where there's more financial investment. So they kind of rely on charitable investment or academic or university investment. So the MS STAT trial, for example, is being sponsored by the UK MS Society. And so that's one side of why they're a little bit slower. And the other side is to see an effect of these medicines takes a little bit longer, because to see a change in brain volume, you just need time. And that's why, even though it seems like progress is slow, there is actually an awful lot happening in this field. So it was a very important question, and thank you for asking. So I suppose it kind of comes down, it sounds like it was a flare of your older symptoms rather than something brand new. So in that sense, you could probably be slightly reassured that it's not a brand new symptom, because that would mean that there's new activity elsewhere in your body. Even though it is something that's old and it's kind of come out, it doesn't mean that it doesn't sort of leave its mark. And COVID is a particular kind of thing, and we've seen that in many people with MS, that COVID can really heavily impact people with MS. And it seems to do so more than people who don't have MS. We don't quite know why that is. And one of the things that's been talked about with COVID is long COVID. And there are many different theories as to what causes long COVID. And one thing that I think is interesting from an MS perspective is that one of the theories for long COVID is that COVID reactivates Epstein-Barr virus in the body. And so the theory, and it's only a theory, it's not proven, is that reactivation of Epstein-Barr virus is what gives people this severe fatigue and brain fog and all the other things that go with long COVID. But because we now sort of have a larger amount of evidence that Epstein-Barr virus is responsible for MS, if you have a virus that kind of unleashes Epstein-Barr, a separate virus that unleashes Epstein-Barr virus a little bit more, it's going to rev things up again in terms of an MS perspective. So I suppose then what I kind of hinted at it is like, what could be treatments for Epstein-Barr virus? And I suppose as it stands, we don't have something to directly target it, but there are things in the pipeline. So there are a few things that I could mention, and they're all very much at a very preliminary stage, but it's just kind of things for the future that I think will come down the tracks. So one thing, there is a company in Australia called Atara Bio, and they've released it's a compound. It's got a funny name. It's called ATA188. And what it is, it's an infusion of immune cells that target B cells in the body, but only B cells that have been infected with Epstein-Barr virus. So in other words, rather than breaking up all the B cells, like some of the current medicines do, it would only break up the B cells that houses dormant Epstein-Barr virus. And what the company did was they released what's called their phase 1 data, which is kind of just the very, 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 very beginning of a long journey. But it looked very promising, and it really sparked a lot of interest. There's a big conference called ECTRIMS every year, which is kind of the big European MS conference. And they released their results at that from their phase 1. And I have to say, it caused a lot of excitement, and it caused people to rethink this idea of Epstein-Barr virus. And that was before the big study came out from Harvard. So they're working away at that, and they've moved it onto a bigger phase trial. So that's certainly one thing that I think would be promising for the future. The other thing is that there's a UK neurologist, and he's quite well known. Many of you will have heard of him, called Gavin Giovannoni. And he made a clinical observation. He had a patient with HIV who also had MS, and the MS was very active. But the person started drugs for the HIV that targeted the HIV virus. But then he noticed that the MS went quiet. And what he thinks, and it's only again a theory, is that the HIV drugs are killing off the Epstein-Barr virus, and that's why the MS went quiet. So what he wants to do now is to do a trial of giving people with MS HIV drugs for the purpose of attacking the Epstein-Barr virus. Now, that hasn't begun yet, and it'll be a long time probably before results come out. But again, it's kind of a promising, more targeted treatment for the future. And the third thing is that with COVID, there are obviously a great many negative things. There's no end to the negative list, but there are some positive spin-offs. And one of them is the messenger RNA technology that many of you will have heard of, and many of you will have got a vaccine that's based on messenger RNA technology. What has kind of come as a spin-off of that is that Moderna, which is one of the big companies, have released an Epstein-Barr virus vaccine, and it's in phase 1 at the moment. So that's going to take some time, but by using that technology and tweaking it, it may be able to adapt people's immune system as to how it responds to Epstein-Barr virus. We're a long way off knowing what effect it could have in MS, but there are kind of three separate examples of where things might go in the future in terms of going after this virus, Epstein-Barr virus. And then the other potential spin-off from COVID is with all the research that's being done on long COVID, it might give us a better understanding as to the mechanisms of Epstein-Barr virus and what it does and how it leads to how it plays into this problem in the immune system. So there's a lot happening, and a lot of stuff will come out in the future. But I suppose in the short term, in terms of your symptoms here and now, our usual recommendation would be not to go with steroids if it's something you've had before, and to work hard with the physiotherapist and your occupational therapist as much as you can, and whatever is within your ability at any particular point in time. So thanks for the question. Yeah. It's both. And it depends from person to person. So it depends what part of the person's body has been affected by MS. For many people, they describe sort of just a tiredness they find hard to put words on, but it's tiredness that's different to normal routine tiredness, and just sort of things that might have in the past been no problem, like tasks and work, or keeping up with a busy day at the weekend with your friends and your family and all that kind of thing. Certain things might just seem like it's a bit too much at that point in time. And we don't quite know why fatigue happens to that degree in MS. A bit of it, we think, is when kind of delving into the sort of the mechanisms of the disease. When you take back myelin off a nerve, it changes how there's little ion channels. So ions are things like sodium and potassium, and that's what sends the signal down a nerve. When you take the myelin off, they change, and it means the nerve is put under more stress and more pressure, if you like. And at a certain point, it kind of has to give. And the nerve, then there's little powerhouses in the nerve cells called mitochondria. And our theory is that the mitochondria eventually sort of get overwhelmed and stop. And because mitochondria produce energy, we think that those guys being lost in the nerve cells might be one of the factors that in terms of why people with MS experience fatigue to the extent they do. Now, it's not the only reason, and there are many other things that are important. So what we've learned recently is a condition called sleep apnea is a bit more common in people with MS than people who don't have MS. So that's treatable, and it has to be tested for first. The other thing is that things that are common, and many people in the world will experience depression or low mood. And depression or low mood commonly has fatigue as a part of it. So what we do know is in MS that depression is a bit more common. Now, it's not to say that depression is the only cause of fatigue, but it can be a factor that could be maybe reversible or treatable, because there are good treatments for low mood or depression. The other thing is in terms of looking for other medical conditions, it's always important. So for example, a low thyroid or a low iron level, or those type of things, or a low B12 level. they're all sort of treatable or reversible in terms of trying to give somebody more energy if they do complain of fatigue and MS. But it's kind of worth teasing those things out maybe with your MS nurse or your GP or your neurologist if it is a symptom that's really kind of getting on top of you. Well, I can give you a specific example then. So there's a class of medicines called Bruton's tyrosine kinase inhibitor, or BTKI, is the short. So they're in phase 3 trial at the moment, and there are 3 of them. There's enabrutinib, venabrutinib, and ibrutinib. So what phase 3 again is, just to recap, is it means that that's the last stage of where you compare a medicine usually to a different current MS medicine. And if the new medicine proves to be better, then it'll get approval from the regulators. Now, those BTK inhibitors that are in phase 3 trial, those trials are probably due, the first trial will probably wrap up towards the end of this year, and many of the other trials will wrap up in the beginning of 2023. But there's a bit of a lag time between the trial finishing and getting regulatory approval. And then after the regulator after the regulator approves it, there's a bit of haggling between the company and the health body. So in our case, the HSE. So there's a cost. So the pharmaceutical company and the company will negotiate a cost. So it's close, and it's hard to put a timeline on these things exactly. But I would estimate probably within 2.5 years, those particular class of medicines will become available. They probably will replace some of the existing medicines because they're a little bit more targeted, and we think there's less off-treatment side effects. But because we don't have them yet, we don't quite know. So it's a little bit of an unknown, but they're looking very promising, and they're a tablet form of treatment, which is attractive because they'd be something that people could take themselves at home. Yeah, so it's hard to put a timeline exactly on these things, but I suppose broadly you're looking at 5 to 7 years from the beginning to something being approved. But it's very variable from drug to drug, and it depends on the nature of the trial, and there are lots of kind of variables, and it depends on, for example, there were many trials that were up and running and then COVID hit. So that put the brakes on a lot of things for a period of time. So things where you might have expected progress a little bit sooner, with the nature of COVID and everything, all the uncertainty that brought, it did impact on research significantly, and things like clinical trials. In terms of the order of priority in a hospital, emergencies always, in terms of COVID, comes to the front ahead of research. But research hasn't stopped, and drug trials haven't stopped, and they're still ongoing. How they're done is being changed because of COVID. But again, in another strange way, COVID has taught us lessons in terms of research as to how a drug trial can be run and new ways of running drug trials. So things that were discovered in COVID earlier on in it were things like dexamethasone. And that was done very quickly, far quicker than older drug trials were done. So we might hopefully be able to speed up in a safe way drug trials. So the way things are now doesn't mean that it will always be that way. Yeah, I suppose the first thing is kind of, and I'm not asking you directly, but is what medicine you're on. And then when you know what medicine you're on, there are common side effects with it. So for example, interferon, which would be Rebif, beta-seron, or there's a couple of other ones, just if they've gone from my mind. But having a sort of flu-y side effects would be very well recognized side effect of interferon. So if that's the case, by chatting with your MS nurse, and then you might begin to see a pattern emerge in terms of, so for example, people who take Rebif, which is 3 times a week, would often say they feel flu-y the day after. So they'd get this flu-y feeling sort of predictably 3-4 times a week and just feel a bit run down. And then by talking with your MS nurse, you might be able to come up with a strategy to reduce that. So what many people would do is they do their interferon injection in the evening rather than the morning. And that would allow you to kind of sleep off some of it. And then also to take maybe a paracetamol tablet before the injection, about half an hour before. And that would also further reduce the side effects of it. And then I suppose if time goes by and you still feel, look, this is a side effect of the medicine and it's getting too much for me. If you've, you know, done all those tricks, the next thing would generally be to go back to your MS nurse and have a chat and say, look, are there alternatives? Are there other options? Because the answer is there usually are other options. And just because you were started on medicine A or medicine B or whatever it is, it doesn't mean that you have to stay on that forever. And with the growing number of medicines available, people are changing medicines more and more. Whereas in the past, you might have had somebody on the same medicine for 20 something years. Now we see people who've been on 3 or 4 different medicines or even more. So it's very possible to change if something's not agreeing with you. And it's a case of kind of discussing that with your nurse and figuring out what's the best plan for yourself.
Right. Thank you.
No problem.
I just wanted to ask, what is the story about Sativex? Is there any sign of that coming on stream? A lot of people ask for it.
Yeah, absolutely. So the situation is it was turned down in terms of the cost. So the cost the company are looking for is beyond what there's the pharmacoeconomic department, which is based in St. James's, and they determine whether there's a benefit versus the cost of every new drug. And as it stands, the cost is deemed prohibitive. So that might change, and certainly, you know, we hear a huge amount at the moment in the media about products that are derived from cannabis, and that sort of gives it extra attention. But it kind of boils down to the cost that's stopping it being.
I do know a few people who have paid for it privately for a few months.
Yeah, it's just so hugely expensive. That's the thing. Like there wouldn't be many people who'd be in that kind of a position, or
to be able to continue with it once it was whether it would work or not, and you know, it worked marginally, but not enough to be able to spend that kind of money on an ongoing.
And I think that's kind of the discussion that the regulatory authorities are having, is that the cost is such. And they're saying, well, look, is it going to give that much of a benefit that we can justify charging the state that amount of money? And that's really what the trade-off is. I previously worked in the UK and I trained there, so I'd seen people who'd been prescribed it, and I suppose people would typically report that it does seem to help pain. It does help muscle stiffness. Some people say it helps their bladder, but with any medicine, it varies from person to person, and because everybody's unique, everybody's genetic makeup is unique, and what that means is how the person breaks down a medicine differs from person to person. And just because one person who maybe writes a blog on the internet or whatever says it's great, it doesn't necessarily mean it's going to work for everyone. And certainly we've seen that for people with epilepsy who take cannabis-based products. Some people get a really good response, but it doesn't mean that everybody will. So I suppose time will tell if it does become approved, and we can sort of get a better feel for, in an Irish context, how well it might work. So I suppose it's kind of an unknown at the moment.
Okay, thanks.
No problem.
How long do you think they're going to be, like, in relation to cannabis-based products? There is, like, I've only on a personal level now, I totally not. But like CBD has really assisted in relation to sleep, in relation to pain, in relation to, now, to be very honest, there would be some THC sort of thrown into that CBD as well, but like, you know, build a bridge, get over it. And I've no problem building bridges. But like, when do you think, like, they're going to look at the impact?
So I suppose there's two sides. When you look at MS treatment, as it kind of was getting at in the talk, there's the symptom treatment and there's the disease modification side of it. So there was a trial previously called the Cupid trial, which looked at cannabis, And what it showed in progressive MS, it had no impact on disease progression. So what that means is we kind of park cannabis as having an impact on the disease itself, but we, as many people with MS would use or take cannabis, it would seem that it does have a good effect on the symptoms of MS. So it can have a positive effect on nerve pain. It can sometimes help with sleep, insomnia, difficulty going to sleep. It can help with various different things. I suppose the thing is, at the moment, we don't have pharmaceutical grade cannabis products available to prescribe. So you can buy cannabidiol from health food shops. It's fairly readily available.
Yeah.
But what we've seen from our colleagues in RCSI, they did a study where they analyzed the strength of CBD in the same product and in a number of different products to see how much does it vary from sample to sample. And there's huge variation is the short answer. So with any medicine that you want to have an effect on the brain, generally what you would like is for it to reach a steady state in the system and to stay at that. And you don't really want big dips or troughs in the level. And that's kind of how we think of in terms of when we use anti-seizure medicines for people with epilepsy. You want to keep things constant. You don't want things to be going up and down and up and down. And because CBD at the moment is only available for people to buy themselves rather than being at a fixed concentration, like most medicines would be fixed. So you'd know there's this number of grams or milligrams per tablet. It's then hard to sort of recommend it for use because we can't say, look, there's this version we can prescribe, because there's nothing we have available at this point in time today that we can prescribe that's approved. That probably will change in the future, but I don't know. It is kind of a hot topic, and there's a lot of discussion about it, and certainly people are advocating for its availability on a more widespread basis. And that kind of ties into this question about Sativex as well, which is a cannabis-based product. But there may be other ones that will become available. There's an epilepsy-based drug called Epidiolex, which is CBD in liquid form, and it may become available in Ireland for seizures for epilepsy, but we don't know whether that will then be, whether that'll then allow us to use it for people with MS, and I suppose that'll be a different question. But certainly, there's no shortage of discussion on it. It's certainly a hot topic.
Thank you.
No problem.
Can I just ask about progressive MS? And am I right in saying that the Ocrevus is still the only treatment available, or is there anything else in the pipeline?
Well, I suppose it's, when you say it's the only treatment, it's the only disease-modifying treatment. Is really, it's not to be pedantic, but just. I suppose when somebody does have progressive MS and they come to our clinic, we'd still look at everything we could do in terms of treating their pain, treating muscle stiffness, treating mood, treating, whatever we can, we'll do our best to do. You are right. Ocrevus Ocrevus is the only medicine approved for primary progressive MS, and there are sort of caveats with it. It seems to have an effect only when it started earlier in the disease, is our kind of understanding from the trial data. And there are other kind of things that might influence how well it works or not. There's a newer medicine that's come out called Siponimod or Mayzent, which is a tablet treatment for secondary progressive MS. And again, it's a little bit selective. It's only for people with what's called active secondary progressive MS, but it has been licensed for that use. So what that means is if people have secondary progressive MS and have activity on their scan or have relapses on top of the secondary progression, then their neurologist could consider prescribing Siponimod. The trial data, it did show an effect, but it wasn't huge, like, so it was fairly modest. But it's encouraging, and the reason it's encouraging is because up until now there weren't any disease-modifying drugs, but even to see a hint of something having some sort of an effect is a big step forward to get to that point. And then it kind of gives us grounds for things to work on for the future to get better again, which I think we need to do.
Thank you, Dr. Kearney, for all your...
No problem.
Thank you very much.
Yeah, you've given us really a lot of food for thought. And thank you for your time late in the evening as well.
I think we've gone way over your time as well. Thank you so much for your generosity.
No problem at all.